You know, when you look at emergency cardiac algorithms from all over the world, whether that's the UK Resuscitation Council, the American Heart Association, or the guidelines right here in Australia for tachy and bradyarrhythmias, there's really this one ultimate primary decision point that just completely stands above the rest.
And that singular question is the patient stable? This isn't just some academic exercise, folks. Answering this one question literally dictates your entire clinical pathway. It's the absolute fork in the road. It determines whether you, as the clinician, have to act immediately with a physical intervention, or if you actually have the luxury of time to run a few more diagnostics. Okay, let's dive into this. Section 1. Assess before you act.
So before we can confidently answer that big stability question, all these universal algorithms require us to start with a standard systematic approach. You know the drill. Start with your ABCD assessment, get them on a cardiac monitor, give oxygen if they need it, and establish IV access to draw some labs. But here's the thing. The most critical initial hurdle you're going to face is step 4, figuring out if the clinical picture you're looking at is actually being driven by a primary arrhythmia. And this brilliantly illustrates that exact point. Think about it. If your patient is tachycardic just because of external factors, like they have a raging fever or they're in severe pain, well, you treat those underlying issues first, right? We're not quite in advanced life support territory yet. But if you rule those external factors out and the arrhythmia itself is the main culprit, your focus has to shift entirely to assessing their stability. Moving to section 2, symptomatic versus unstable, a critical distinction.
There's this super common clinical myth that kind of blurs the lines here. We really need to separate the broad idea of a patient just seeking care from the extremely narrow red alert definition of clinical instability. I mean, by definition, almost every single patient who walks into the emergency department is symptomatic, right? They might feel dizzy, they might be having palpitations, or they just feel really awful. But that does not necessarily make them unstable. Unstable specifically means the arrhythmia is actively causing signs of poor perfusion or heart failure. Only a tiny fraction of those symptomatic patients actually meet the strict criteria for being unstable.
Let's move to section 3 and see how this builds. The 4 adverse criteria, or the clinical red flags. To figure out exactly what an unstable patient looks like, the algorithms give us exactly 4 adverse criteria. The first of these massive red flags is shock and hypotension. Now, listen closely here. We are talking about general evidence of severe circulatory failure. Clinically, we usually define this as a systolic blood pressure dropping below 90 millimeters of mercury. This is an urgent, incredibly clear indicator that the vital organs are simply not getting the blood flow they desperately need to survive. Our second criterion is acute coronary chest pain. And we're not just talking about any vague chest discomfort here. We mean a brand new onset of ischemic cardiac-type chest pain. You're going to find that this symptom is particularly glaring in patients who are dealing with rapid tachyarrhythmias. It happens because the heart muscle itself is basically crying out for oxygen, since it's beating so fast and so inefficiently. Now, what's really interesting about this slide is our third criterion, altered mentation. This one is a huge red flag. If your patient suddenly shows up with a new onset of confusion, maybe a reduced level of consciousness, or really any acute change in their mental state at all, you need to pay attention immediately. Why? Because this is a clear, undeniably direct sign of poor cerebral perfusion. The brain is literally being starved of oxygenated blood. And that brings us to the fourth and final criterion, pulmonary edema, or APO. This is a new onset of fluid backing up into the lungs. Think of it like this. When a heart rate is way too fast or even way too slow, the heart becomes this incredibly inefficient pump. Because it just can't push blood forward effectively, all that fluid physically backs up into the pulmonary system, basically flooding the lungs. Before we start looking at the actual treatment pathways, I want to toss in a pretty surprising physiological fact just to give you some solid context. Historically speaking, rate-related symptoms and these severe adverse features we just talked about, they're actually quite uncommon at heart rates less than 150 beats per minute or above 40 beats per minute, unless the patient already has some underlying structural heart disease. So absolutely keep those numbers in the back of your mind when you're evaluating if the heart rate is truly the primary culprit driving the instability. Moving right along to section 4, time versus urgent action, the clinical clock. So we've nailed down the 4 criteria. Now we really need to look at the real-world consequences, because this classification completely dictates your clinical clock. Let's contrast the 2 outcomes here. If your patient doesn't meet any of those 4 adverse criteria, they are considered stable. And when a patient is stable, you have time. You have the luxury to perform more advanced diagnostics, run a full 12-lead ECG, wait on those lab results, and carefully map out a pharmacological strategy. But if they are unstable, if they hit even one of those red flags, you must take urgent action right now. We are talking about immediate, emergent physical or electrical interventions, like synchronized cardioversion or pacing. There is absolutely no time to wait. So the crucial point is captured perfectly in this quote from the source material. In cardiac emergencies, being unstable is not a vague description. It is a specific clinical trigger for urgent action. You can't just look at a patient from across the room and say they look unstable just because they're a bit dizzy or anxious. No way. It requires precise recognition of those 4 specific criteria to pull that clinical trigger for a life-saving intervention. Which leaves us with one final thought. Next time you're assessing an arrhythmia on a high-stakes shift, will you let general symptoms like dizziness or palpitations distract you, or will you look strictly for those 4 adverse triggers of instability? Keep this focused mental framework right in your back pocket. Assess systematically, separate the naturally symptomatic from the truly unstable, and you'll be more than ready to deliver life-saving interventions with absolute precision. Thanks so much for joining me on this explainer, and keep learning.